Hi everyone, Dr Hungerford here. Just wanted to give you a little bit of an update on some of the in-room and in-office procedures that we can do. Try and help your patients delay the time until recovery. These are things that you can consider maybe a little bit earlier than what you're already doing, or they may be for patients that you haven't thought a procedure could be an option. So let's have a bit of a look and see what we can find. So to give you a bit of an idea overall, minimally invasive foot and ankle surgery, or MIFAS, it's been around for quite a while and it uses quite common equipment. Everyone would know what the Black's file is, and to give you a bit of an idea on the scalpel blades that I'm using, most people would use this 62 blade as a beaver blade for their nail procedures, such as the partial nail avulsion, and I'm using a 67 mini beaver blade, and you can see it's really quite thin. It's less than 2 millimeters, means that the incisions that I make are really quite small. Some of the equipment that you may not be as familiar with is the fluoroscopy, which is our x-ray, and I've got this machine in rooms, which really helps me to get an immediate understanding of whether this procedure has been successful, and also for preoperative surgical planning as well. Now over here we have our ASADA minimally invasive drill. And this is basically, if you think like a dental drill, it's a similar type of an idea, and I use this to burr bone away. Now, different procedures that we can do in rooms, there's quite a few different things that we can do. So obviously we've got our normal procedures like our ingrown toenails, which we may do a nail avulsion, partial or total, and then we also have our matrixectomy or sharp nail procedures such as the Winograd, where we're taking a bit of skin and tissue away and then suturing it. We have our Verruca Pedis procedures, whether that's a Curettage or Falknors multiple needling, and then we can do things for flexible and semi-reducible hammertoes in rooms quite easily without having to impact any bone whilst we're doing that. That means that some bone spurs will be able to be removed as well as tendons and capsule released. And that depends on sort of the patients that you're seeing, and it may be that you have patients with really chronic interdigital corns that may be able to be helped through some of these techniques. Now, things like nerve entrapments, including Morton Neuroma, I'm going to touch on a little bit more because there's a really good procedure that we can use that's minimally invasive, quick recovery, and just involves transecting the deep transverse metatarsal ligament. Now, different skin and nail conditions like foreign objects can, be a part of it, but getting that opinion can be a big thing. And like I've said, superficial foreign object removal is something that I do in rooms here. And then other different things for nerve entrapments, advanced procedures that we can do in rooms. To give you a bit of an idea, MIFAS, minimally invasive foot and ankle surgery, it's small incision, which means it's going to be reduced pain and reliance on medications. And most of my patients are just having Nurofen and Panadol, and most of them are stopping after, if they even start, after the 24-hour period. There's going to be less swelling, there's no requirement or less requirement for internal fixation. Those smaller keyhole incisions, like I said, showing that beaver blade, typically less than 2 mils. Sometimes they are a little bit bigger, but a lot of the time they only need a steri-strip rather than stitches. That means that there's less risk for infection, it's a quicker recovery, and a quicker return to their full activities of daily living, and hopefully moving on from there in a lot less pain. To me, this means it's better outcomes, it's safer practice, hopefully a happy active patient, the happy surgeon being myself, the happy referrer being yourself, and that happy supporting health team as well to make sure that that patient's holistically quite well. When we start thinking about, okay, when are these type of options appropriate? I think a really classic one that we see quite often is that flexible hammertoe. And in this picture, this is a gentleman that I've reviewed recently who has an abductor varus hammertoe of the 5th, and that lateral aspect of the DIPJ and that distal lateral nail is where the weight-bearing surface is of that 5th when standing. This is a fantastic option, being the Flexor Tenotomy is a fantastic option for this patient because it's totally reducible. It's a flexible toe. It can be brought into a corrected position. And the surgical plan for this type of patient is that we would release the flexor extensor, the flexor and the extensor tendons potentially, and some of those plantar capsule aspects so that we can make sure that that toe is going to be corrected and held into a position. A thing that I do quite often myself is I tape these toes into the corrected position for 4 days to ensure that this is going to stay into that position. 4 weeks, sorry, not 4 days. And when it's been corrected into that position for the 4 weeks, it's more likely to stay in that position once the healing's done. That means that that plantar capsule is going to be scarred into a corrected position. It means that the flexor is going to be completely released, allowing it to come into that more dorsiflex position, and that a lot of that abductor varus deformity is going to be corrected. Now you may also see these type of things in between toes or on the apex of, say, like the second toe in a mallet toe deformity, and a flexor tenotomy can be a really good way to go. When there's multiplanar deformity, such as in our classic hammertoes, we may need to do some more work, such as for the extensor tendons at the capsular level of the MTPJ, and that can be some of the types of procedures that I'll undertake in rooms for these type of hammertoes that are reducible or semi-reducible in nature. A little bit of a video just to give you a bit of an idea of how we're doing this. So this is a 4th toe. I have already undertaken the 3rd toe there. You can see that Mini 67 blade, and just through a very small percutaneous incision underneath, you can see that we get a really good release there. I'm also doing a bit of capsular work just to really free it up. And I know it's a little bit overexposed here, but what you are seeing is that I'm trying to over straighten that toe to make sure that it comes up into the corrected position. Now this patient is a patient that has had multiple concerns previously, including a partial amputation of his second, and this is a really good option for this type of patient to prevent further amputation and concerns due to his chronic diseases. What we can also do through these minimal incisions is small ostectomies. A lot of the patients that we see in general podiatry practice for our general care have mild spurring of around the DIPJ or the PIPJ, which are causing the interdigital corns and potentially wounds or ulcers that we see. In this image here, you can see that there's a little bit of a spur, and I've zoomed in a bit more on this one here. You can see that this spur, quite large. It's likely that it is causing this wound here as it's sort of moving across onto that 4th PIPJ. And these are the type of things that we can manage quite easily through a minimal incision, again in rooms, in office. Undertaken through a Black's file, and I've got a little bit of a quick video here just to give you a bit of an idea. This is for a 2nd toe. You can see that I'm making the incision there, and once I'm in that right spot. And then I'm going to be going straight down to bone, and once I'm at that area, I'm going to be clearing away some of the capsule around there so that I can manage to get the Black's file into that position a little bit easier. Once that capsule has been relieved off of the bone, and I've got a nice portal there to be able to place the Black's file in, that's when I'll start removing some of that bone. And you can see that here. Now I'm going from the dorsal aspect, and I know exactly where that bone spur is going to be, the osteophyte, and so I'm just trying to reduce that as much as possible from that area. This patient ended up just having a steri-strip and was healed at about 5-6 days post-op when I reviewed him. A really good outcome for this type of patient as well, who's had chronic pain in that area. Now, a technique that you may not be as familiar with is one for the Morton's neuroma. Now, of course, the gold standard for Morton's neuroma is a neurectomy, where the nerve is removed from a dorsal approach. But for patients that may not be able to have as, the time off of work, they need something that's a quicker recovery, they're happy with a slightly reduced success rate, then this could be a good option for them. Now, what I do is through a dorsal approach is release the deep transverse metatarsal ligament, again through a 2mm incision, at times ultrasound assisted, and really patients are healing within 4 days. Very few need any strong medications, and most are only using paracetamol. I do keep my patients in a post-op shoe just for that 4 or 5 days until I review them again. and I'm typically getting over 80% success rates in the resolution of pain when I'm reviewing them at sort of their final review around 3 months. But the literature indicates that that's pretty typical, with success rates up to 83%. Now this is one that I do say, you know, if it is a larger neuroma, then it's potentially that, you know, it's not going to be as successful, and I try to steer those patients towards a neurectomy. But for the smaller neuromas that are they're resistant to your conservative care, this could be a really good option and something that we can do in rooms quite easily, quite safely for them. Of course, the Verruca Pedis, as we mentioned, our typical warts, you know, in kids, of course, if they're not painful, we don't need to treat. But once you know, they're an adult, they may have exhausted their conservative, or they may be a child that is finding ongoing pain. There's a few different options that we can do. One of those is the Falknors needling, where it's a multiple puncture technique to try and push that virus deeper into the body. And this can be a really good option for a lot of people, particularly if it's over a weight-bearing area where we don't want to increase the scarring. Obviously, it takes a little while for the body's inflammatory response to take hold and to make sure that it's recognizing that virus and get that immune response that we're wanting. A lot of the time, if it's in a safe spot, I will opt to undertake a Verruca curettage, and I phenylize the base as well to ensure that there's no virus left, basically. This doesn't delay the healing too long, and I find that my successful outcomes are much higher in doing so. And this is a common procedure that we do. Definitely, you know, I know there are some podiatrists that are doing these procedures as well, which is great. And looking at those options, I do find that a lot of podiatrists refer them through to me when it's a little bit more of an abnormal position, as in that it's weight bearing, maybe under one of the metatarsophalangeals or towards the heel, where that risk of scarring is a lot higher. These are something that I'm quite comfortable with and making sure we reduce that rate of scarring. And then of course, you know, we have our really gnarly ingrown toenails. You know, a few different procedures. Once it gets to this stage here, a Sharps procedure where we're removing that hypergranulation tissue is going to be the best option. But of course, a lot of you will be doing partial nail avulsions, total nail avulsions as well. And these are quite a common procedure that I do within the clinic. What we're seeing here is the Sharps nail procedure. And you can see that this is pre-op and this is immediately post-op before we even have the tourniquet off. You can see how much of a nicer nail that is within about 15-20 minutes. Now, something else that I wanted to have a bit of a chat to you about was the high volume injection therapy. This is something that I've been doing a lot of, using local anesthetic and saline for a number of different conditions. I'm finding that it's incredibly effective for my chronic pain patients across a number of different conditions, including the tarsal tunnel, that first, second TMTJ nerve entrapment, when we have a bit of dorsal osteophytes, the Morton's Neuroma injections, you know, as a high volume as well as an isolated injection, definitely first MTP, plantar fasciopathy, Achilles tendinopathy, and some of the higher volume tendon stripping. But there's so many different options that you can use or so many different pathologies you can use injection therapies to help. A big part of this is the nerve adhesions, and for patients that are post-surgery that may have nerve entrapment around the scarring, I just find that this type of therapy works really quite well. As you may be aware, we do run the injection therapy courses as well. If that's something you're interested in, please reach out and we'll see what we can do. But I thought definitely worth mentioning as an advanced therapy. I find that in using the high volume injections in conjunction with the photobiomodulation therapy, PBMT, and you may know it as laser therapies, that I do get really quite successful outcomes for a lot of my patients where we're able to then avoid surgery. Of course, if you have any questions, please feel free to email or call me at any time. I'm more than happy to organise a chat over Zoom and then we can sort of go from there as well. If there are any questions, reach out. There's a bit of information on my website as well, but hopefully this finds you well, and I look forward to chatting soon. Cheers.